Now that we've covered both intra and extravascular hemolysis, let's reinforce these concepts by talking about three hemolytic anemias that cause predominantly extravascular hemolysis, with a little intravascular on the side, just for good measure. We begin with an old favorite from biochemistry, glucose 6-phosphate dehydrogenase. Call it what you will. The Will Rogers Highway, the Main Street of America, the Mother Road. Route 66 is one of the most iconic highways in the world, spanning 2,400 miles from Chicago to Los Angeles. Today, many areas of US 66 have fallen into disrepair, but in this sketch, we're going back to its heyday. First of all, notice that we've included a Norman's Motel sign in the bottom left of the scene, in reference to the Erie Motel where we were introduced to the intravascular hemolytic anemias. The name Norman reinforces that these next few hemolytic disorders are usually considered normocytic anemias. In reality, depending on the degree of reticulocytosis versus hemolysis, the mean corpuscular volume, or MCV, can vary. But on test day, they likely won't emphasize these changes. All right, where were we? Glucose 6-phosphate dehydrogenase, abbreviated G6PD, is the rate-limiting enzyme in the pentose phosphate pathway. So on the side of the truck, you'll see Route 66 produce for G6PD, as well as a map with 3 stops along the route. 3 Ps for pentose phosphate pathway. If you remember all the way back to biochem, the pentose phosphate pathway is used for the synthesis of fatty acids and cholesterols, generating NADPH in the process. NADPH carries electrons, so at Sketchy, we represent it with an electrolyte-rich sports drink. This time it's getting dropped, because we're going to be looking at what happens when red blood cells are deficient of G6PD and therefore NADPH. This electron carrier aids in reduction reactions, which are vital for maintaining stores of the molecule glutathione. Glutathione is the primary free radical scavenger of the RBC and absorbs all the oxidative stress that comes with being a busy blood cell. To recycle glutathione so that it can be used again, it needs to be reduced, hence the need for NADPH. Well, no G6PD means no NADPH means no reactivating your glutathione. So pull up those pants, my friend. No glutes for you. A lack of glutathione means that red blood cells are left exposed to a lot more oxidative damage, as depicted by the sparks flying from those faulty hinges, oxidized with rust. In times of physiologic stress, especially infection, patients with G6PD deficiency will show symptoms and signs of intra- and extravascular hemolysis. Hemolysis can be moderate to severe and generally takes 2 to 3 days to manifest. G6PD deficiency is an X-linked recessive disorder, depicted, as always, with someone cowering, receding, if you will, behind an X shape. X-linked disorders are most commonly seen in males. For the most part, women with the G6PD mutation will be asymptomatic carriers, but they can develop a less severe form of the disease through lionization of the normal copy of the gene in RBCs. Okay, without glutathione around, what absorbs all that oxidative stress? Well, hemoglobin does instead. When the stress is bad enough, hemoglobin becomes denatured, insoluble, and clumps into what's called a Heinz body. Heinz bodies are seen on the blood smear using supravital stains such as methylene blue or crystal violet. They show up as little dots in the cytoplasm, kinda like little watermelon seeds. Just like what we saw in the thalassemias, these inclusion bodies damage the RBC membrane. When these cells make it to the spleen, the Heinz bodies and damaged membranes are partially chewed off by splenic macrophages, forming those characteristic bite cells seen on peripheral blood smear. They have a literal bite taken out of them. Eventually, these RBCs become too worn down by the combination of Heinz body damage and macrophage bite attacks. As a result, most of these RBCs are phagocytized in the spleen. This is called extravascular hemolysis and is represented by the splenic big rig with the macrocage on the back, full of RBC tomatoes. This is the predominant mechanism behind the hemolysis seen in G6PD deficiency. Some RBCs, however, don't make it that far and undergo cell death intravascularly. The red tomatoes that didn't make it to the truck and lay hemolyzed on the ground represent intravascular hemolysis. So remember all the pertinent lab findings that accompany both intra- and extravascular hemolysis. At Tornado Alley, we illustrated what happens when the RBCs are hemolyzed in the spleen. The most important lab values to keep in mind are increased serum LDH and unconjugated bilirubin, the latter of which causes jaundice. Keep those flying T bags in mind as well, a recurring symbol for increased reticulocyte production by the bone marrow, as your body attempts to keep up with the high RBC turnover. And at the Peaceful Night Hotel, we illustrated what it looks like when those RBCs spill their contents directly into the vasculature. In addition to LDH and bilirubin, look for some free hemoglobin to show up in the serum, with a corresponding decrease in haptoglobin. Also remember that drain pipe, because heme is damaging to the kidney tubules and can cause AKI. Most patients with G6PD deficiency are completely asymptomatic at baseline, however, with no signs of hemolysis on labs. That is, until the patient is exposed to an environmental factor. Most commonly infectious agents are drugs, which can precipitate an acute hemolytic episode. The classic presentation consists of an acute onset of dark urine and jaundice, due to heme and heme breakdown products. There may also be abdominal pain or back pain, as the kidneys just can't handle all that heme. These symptoms usually occur 2 to 4 days post-exposure to the causative agent or bug. Infection is the most common cause of hemolysis in G6PD deficiency. It can be anything from a bacterial pneumonia to viral hepatitis. Either way, just make sure to wash your hands after handling those radishes. I don't know, there's just something about them. Unsettlingly flagella-like dangly bits. Numerous drugs are implicated as well. Anti-malaria or anti-tuberculosis drugs, like primaquine and dapsone, are strongly associated with precipitating hemolysis. Enter our dapsone deputy, stage right. The antibiotic trimethoprim sulfamethoxazole is another well-known trigger. Hence the stacks of our recurring stinky sulfa eggs in the back there. And, of course, don't forget fava beans. The favorite test question of biochem professors the world over. They go great with a bottle of Chianti, by the way. G6PD deficiency is seen more frequently in individuals of Mediterranean and African descent. Sound familiar? That's right. It's just like spherocytosis, sickle cell disease, and the thalassemias. The reason is still the same. Being a carrier for G6PD deficiency confers protection from malaria, often a more deadly disease than these inherited hemolytic anemias. So we've added some protective mosquito netting to the bed of each truck. As you may have noticed, hemolysis generally occurs when RBCs are defective. However, an overactive immune system can inadvertently train its sights on normal RBCs, resulting in an autoimmune hemolytic anemia, or AIHA. It comes in 2 forms, warm and cold, based on the temperature at which the autoimmune-mediated hemolysis takes place. Let's start with cold AIHA. Sounds pretty refreshing after spending hours on the road, doesn't it? In cold autoimmune hemolytic anemia, IgM autoantibodies against RBC surface antigens develop, as depicted by the IgM snowflakes. The term cold references the fact that IgM cold agglutinins only bind erythrocyte surface antigens at temperatures below 30 degrees Celsius, or 86 degrees Fahrenheit. Weird. This is obviously not the normal body temperature, which is 37 degrees Celsius, but it is roughly the temperature of the extremities, especially when exposed to colder external environments. The binding of IgM in the extremities leads to the formation of RBC aggregates, which are cross-linked by IgM globulins. These clumps of cells are small, but they can still mess with blood flow through the small capillaries of the hands, feet, and ears. As a result, blood flow to these areas is diminished, leading to ischemic pain that resolves with warming and disassociation of IgM from the RBCs. Interestingly, cold AIHA and Raynaud phenomenon are very similar in pathophysiology. Raynaud's presents with pale, painful fingers and toes when exposed to cold environments that resolve with warming. It's a pretty common benign condition. In warm autoimmune hemolytic anemia, IgG autoantibodies, not IgM, form against RBC surface antigens, as depicted by the IgG shape incorporated into the sign for meat on a stick. Because nothing says American like a novel and absurdly efficient way to ingest hunks of meat. In both cold and warm autoimmune hemolytic anemia, these surface immunoglobulins bind and activate the complement system, especially C3. Hence the sign for complementary coffee. Also, you see the message underneath? Bound immunoglobulin and complement proteins on the surface of the RBC can act as opsonins. This is from the Greek word meaning prepared for eating. Fitting, because this process involves coating the RBC and facilitating phagocytosis by macrophages in the spleen and liver. These phagocytic cells comprise what's called the reticuloendothelial system. In many cases, only the early components of complement, including C3, have a chance to accumulate before the macrophages of the spleen and liver bite off the pieces of complement-coated cell membrane, forming bite cells. This happens more so in warm AIHA than cold. So let's put a big bite in that steak, shall we? As the membrane becomes smaller and has to stretch out to cover the same volume, some of these cells turn into spherocytes. Recall from our extravascular tornado sketch that spherocytes don't last long before they're gobbled up by the spleen. And that's the main theme here. In both warm and cold hemolytic anemia, the cells are covered in immunoglobulins and complement, leading to extravascular hemolysis by macrophages in the liver and spleen. This process leads to the usual jaundice and splenomegaly seen in other forms of extravascular hemolysis. Pay attention to those lysed tomatoes on the plate as well. RBCs that are more extensively coated with complement proteins, including C5 through C9, form membrane attack complexes. The MAC complex creates a pore in the RBC membrane, causing osmotic lysis of red blood cells right in circulation. So, in some cases, expect intravascular hemolysis, which manifests as hemoglobinemia and hemoglobinuria, elevated LDH, and decreased haptoglobin levels. The resulting anemia in autoimmune hemolytic anemia is variable in severity, but usually mild and normocytic in character. Diagnosis of AIHA, as I'm sure you imagined, involves testing for those antibodies on the RBC surface. Interestingly enough, finding a system for this proved initially difficult. Then, in the 1940s, British veterinarian and PhD student Robin Coombs apparently fell asleep on his train ride and had a dream where he used an antibody against antibodies. Ingenious. His dream is now called the Coombs reagent, and it's still used for a test we call the direct Coombs test, symbolized by this direct coonskin cap, the perfect headwear for those hot summer days, absorbs sweat right into the fur. The direct Coombs test is performed by taking a sample of the patient's blood, washing the RBCs of all the plasma components, and then adding the Coombs reagent. The Coombs reagent is an antibody that binds to any antibody, such as IgG, IgM, and complement proteins like C3, attached to the surface of the cell. So take a look at Davy Crockett over here. See how his sleeve evokes an image of antibodies attaching to antibodies? When Coombs reagent binds to affected RBCs, the coated cells aggregate with one another and form a clump. This is called agglutination and is considered a positive direct Coombs test, confirming your diagnosis of warm or cold autoimmune hemolytic anemia. To finish up, let's talk about a few of the conditions that trigger your immune system to start attacking your red blood cells. Roughly half of all warm and cold AIHAs are idiopathic. We don't really know what's going on there. The other half of cases, however, are associated with some of the usual suspects known to precipitate autoimmune disease. In children, miscellaneous viral infections can precipitate warm AIHA. He's accompanied by our lupus wolf because, in adults, autoimmune diseases are common causes of warm AIHA, with systemic lupus erythematosus being the #1 offender. A laundry list of medications are also associated with warm AIHA. Penicillin, cephalosporins, and the NSAID diclofenac are common culprits. Because of how different these drugs are, it's likely that antibody binding is triggered through a number of different mechanisms, including drug integration into the antigen and direct alteration of surface antigens by the specific medication. Cold AIHA is associated with viral infections, especially EBV in the form of mononucleosis, as well as Mycoplasma pneumoniae bacterial infections. Of course, this by no means is a complete list. Nevertheless, we've included our My Cold Plasma snowshoer, as well as a few of our regular Epstein-Barr patrons, just for good measure. You know, truckers get a bad rap. It's not all beer and meat on sticks and DVTs. They're actually quite a cerebral bunch. Actually, at most truck stops, you're likely to witness a chess game or two. A chessboard filled with B-cell archers and T-cell knights is our recurring symbol for lymphoma. Lymphomas are strongly implicated in AIHA, occurring in about 10% of patients with chronic lymphocytic leukemia. Although the mechanism behind this is unclear, it may be the result of alterations to the immune system caused by the proliferation of abnormal neoplastic lymphocytes. All right, time to kick this popsicle, or fruit, veggie, mystery meat stand. In this sketch, we've covered normocytic anemias brought about by the destruction of red blood cells, both intra and extravascular. In the X-linked recessive G6PD deficiency, inability to form NADPH leads to reduced glutathione stores. Since glutathione is the primary mechanism of absorbing free radicals in red blood cells, oxidative damage from the rampant radicals can lead to membrane damage and even lysis. Hemoglobin takes a hit too, so watch for denatured clumps forming Heinz bodies within red blood cells. When the membrane is messed up, many cells are chomped on by the spleen, forming bite cells, or macrocaged by the spleen. That's called extravascular hemolysis. Cells can also just be too far gone and burst, resulting in intravascular hemolysis. Patients are usually asymptomatic, however, unless they come across infection, sulfadrugs, dapsone, or fava beans. If they do, they may experience an attack 2 to 4 days later, usually presenting with jaundice, dark urine, and abdominal pain. The immune system does its part too, to help you get your kicks on the route to anemia. Things like viral infections, lupus, and drugs like penicillin or diclofenac can lead to the formation of IgG warm agglutinins, which bind to red blood cells. The red blood cells then proceed to get covered with antibodies and complement. The spleen can bite off some bits of red blood cells that go by, those classic bite cells, or even spherocytes. Red blood cells that are completely opsonized by antibodies get gobbled up by macrophages in the spleen. That's extravascular hemolysis. Remember those broken hors d'oeuvres still on the plate too. Some red blood cells covered in antibodies and complement don't even make it to the spleen and get lysed out in circulation. That's intravascular hemolysis. Mycoplasma, EBV, and lymphoma can also cause the formation of IgM cold agglutinins, which clump red blood cells and cause pain and swelling to cold extremities. Again, antibodies activate complement, opsonize red blood cells, or even just cause lysis out in the circulation. Diagnosis can be made by adding Coombs reagent, an antibody to antibodies, to patients' red blood cells, which will cross-link the autoantibodies on their surface to cause agglutination, a positive direct Coombs test. All right, next up, we have one more normocytic anemia to discuss, sickle cell. Won't you get hip to this timely tip? When you make that underworld trip, get your kicks on the river Styx.